Picture a young child in their living room. They are laughing, telling stories, and chattering away comfortably with their parents. In this environment, they are completely at ease. But the moment that same child steps off the school bus, the ease vanishes. Their face locks up, their body stiffens. They enter the school building and become completely silent. This silence is not a tantrum. The child isn't being stubborn, and it is a distinct clinical condition separate from standard childhood shyness. What you are looking at is selective mutism, or SM. It is a specific anxiety disorder where a child consistently fails to speak in certain social situations, like at school or around peers, even though they speak perfectly fine at home with their immediate family. Kids are often quiet the first few weeks, but if silence persists a full month beyond that adjustment period and interferes with learning, it becomes a clinical diagnosis. About 1% of school-aged children experience this, mostly presenting between ages 3 and 8. The unique cruelty of selective mutism is tied entirely to location. The anxiety paralyzes children exactly where they are required to learn, socialize, and grow. It creates a massive geographical gap between where a child is struggling and where they typically receive mental health care. Because the silence is absolute, well-meaning adults often guess at the cause. They might assume the child is on the autism spectrum, intensely introverted, or just refusing to follow directions. These assumptions lead educators and parents to try and solve the wrong problem, which actively delays the precise treatment the child actually needs to manage their anxiety. Without targeted intervention, selective mutism rarely resolves on its own. Instead, it hardens and persists right through adolescence and into adulthood. Years of silence compound over time, severely limiting a student's academic trajectory and making it incredibly difficult to form functional social relationships as they age. Misunderstanding the root cause leaves these children isolated, and because the symptoms vanish the moment they get home, traditional after-school therapy in a clinic often fails to reach them where the anxiety actually triggers. To understand how this anxiety operates, we have to look directly at the classroom environment where these social triggers live. This cycle map shows a student's brain. A question triggers an involuntary physical freeze. Seeing the struggle, an adult answers. This rescue brings immediate anxiety relief. The brain learns silence guarantees safety, reinforcing the mutism every time they're rescued. Without specialized intervention, the traditional school setting accidentally becomes an incubator for the anxiety. Out of sheer kindness and a desire to help, adults trap the child in a permanent cycle of silence. Breaking this cycle requires a clinical approach. Simply commanding the child to speak or waiting for them to grow out of it does not work. The interventions that succeed rely on cognitive behavioral therapy paired with graded exposure. Therapists use behavioral techniques like stimulus fading and shaping, gradually rewarding small nonverbal communications until they slowly build up to spoken words. Approaches like parent-child interaction therapy are highly effective for this. And in moderate to severe cases, doctors may introduce SSRI medications to lower the baseline anxiety enough for the behavioral therapy to take hold. But because the trigger and the accidental rescue happen almost entirely at school, these clinical tools are useless in a vacuum. They have to be deployed directly inside the school environment, and teachers need to be trained on exactly how to respond. Treating a strictly environmental disorder requires physically moving the clinical solution into the exact environment causing the distress. This is where MentalSpace School bridges the gap. They provide Georgia schools with same-day K-12 teletherapy, assigning dedicated, culturally competent therapist teams directly to the students during the school day. This visual illustrates how they remove traditional socioeconomic barriers. The telehealth framework connects straight to the school building, offering $0 care for Medicaid patients, accepting broad insurance networks, and helping districts meet their upcoming HB 268 compliance deadlines. The data from this in-school model shows clear results: an 89% improvement in attendance, a 92% reduction in anxiety, and an 85% family satisfaction rate. When we stop misunderstanding silence and provide accessible, school-based mental health care, we give children the ability to speak and the opportunity to succeed in their own environment. To learn more, visit MentalSpace's school.